Welcome. I'm Sebastian Mahfood, and you're listening to WCAT Radio, the on-air wing of En Route Books and Media, bringing you the dulcet sounds of Catholic wisdom.
Well, welcome to this week's edition of WCAT Radio, Inter Vitam at Mortem. Interviews and discussion with a Catholic bioethicist. I am your host, Dr. Anne Urlakis. I'm a classically trained, degreed bioethicist, and today I have a very special show planned, a very special guest who is both a colleague and a friend. Today I'm going to be speaking with Julie Shocksnider, who is a registered nurse and has spent 28 years working in the field of obstetrics, both at the bedside and as a consultant. Before we begin, let us start with a prayer as we usually do. So in the name of the Father, and the Son, and the Holy Ghost. Dear God, our Heavenly Creator, you are the author of life and of truth, the reality that you will each and every human person into being, created from the moment of conception, bearing the dignity and imprint of your own image and likeness within the very essence of our being, is a mystery beyond human understanding. Please help us to have a greater appreciation of the gift of being created in your image and likeness. Help us to reverence that reality in our brothers and sisters, especially the tiniest and most vulnerable among them. Help us to defend the sanctity of every human life from conception to natural death. We ask this through Our Lady, the Most Blessed Virgin Mary, the Mother of God, in the name of the Father, and the Son, and the Holy Ghost. Amen.
Amen.
Well, welcome, Julie. I am so glad that you are able to join us today on the WCAT radio broadcast of Inter Vitam at Mortem, Between Life and Death. And I am... You are a friend and a colleague. We work together with Holy Resurrection Monastery and do some awesome things up there. And I have relied on your expertise in obstetrics. And we've talked before on bioethical issues. And I just am delighted that you're able to come here today and join me on this broadcast.
Well, Marianne, thank you so much. I appreciate you having me, and I'm looking forward to the program.
Thanks. As we get started, could you tell the listeners a little bit about yourself?
Yes, as you said, I've been a nurse for quite some time, and I'm one of those fortunate people that from a very young age, my mom said that I always said I want to be a nurse. And since there's no nurses or healthcare workers in our family, everyone was they were more into business. We're kind of like, where did she come from? But as soon as I, got into school, I always knew that I wanted to be a nurse, and here I am all these years later. So glad that I had that calling and could participate in it in the way I did and have and continue to. Let's see. So I'm a mother and a wife also, and my husband Tim is an engineer. So we have a daughter who's in her 30s, and an engineer and a nurse ended up making an artist. So
wow.
Yeah. So actually, as we're talking about bioethics and ethics of healthcare and maternity, and that I was early on diagnosed with endometriosis. So they had said, if we ever want to have children, we'll do it now or probably never. And at that point, I was in my second year, going into my third and last year of nursing school. And Tim and I had been dating sometime, and we talked about it and said, let's try for a family. So we got pregnant fairly quickly with our one daughter, and had her with some complications, and then had a hysterectomy not so long after that. So we're blessed to have our one and only child. So that was a difficult time to go through that, and especially at a younger age. You think you kind of have your world ahead of you and that, but it kind of made us stop and relook at that. So I think with that background, I always knew I wanted to be in obstetrics. I felt like it was a vulnerable time for many women, and especially for the infants. And I was always glad that I was able to always practice at the bedside in that area. So I went originally to diploma school, so there's not many of those, if any, out there anymore. That's a 3-year program. And then I went on to get my bachelor's, and we were living in the time in Kentucky, so at University of Louisville. And then I got my master's at Rutgers, Newark, New Jersey. So I've kind of had a varied background in my training and in my practice. If you would have asked me when I first started nursing, is there a variation in practice based on the region you live in, I would have said absolutely not. But now we know there's lots of research out there showing that, and certainly in pregnancy, labor, and delivery, there's pretty wide variations occurring between the region and the outcomes related to that. So I've been privileged, again, to have practiced in quite a few regions of the country and to be able to be exposed to different things that have really given me the background to question, why am I doing what I'm doing, and what does this mean? As a growing up as a Catholic, I really didn't think, honestly, that much as a young nurse in training about that. I went to a secular school, and there wasn't a lot brought up other than, about abortion sometimes, but, that you didn't have to participate in that necessarily. But there wasn't really a full explanation of how, as a nurse, I could step into a role, especially in obstetrics, that I could align myself with my Catholic faith and be sure that I'm honoring the women I'm working with and my colleagues, and honoring my belief system internally. So as I went from organization to organization, I began to learn and grow in the way that I approached the organization and in the way I handled myself as a Catholic nurse. One of the things that I learned to do was to, once the job offer was made, I would always tell them very clearly what I was willing and not willing to do. So examples of it is, like, I was not willing to participate in any type of abortion or abortive type activity with a living fetus. So even if there was idea of wouldn't be able to live outside the, live or whatever their terminology was, I said I cannot participate in that. In an emergency, I said I could go in and help the woman in that, but, in the activity of itself, I would not participate in any of that, and would ask that I not care for that woman, if at all possible, even before and after, just so there wouldn't be that issue. Others are like selective reductions, where there's multiples in the uterus, and sometimes with infertility drugs, there's more babies than actually the mother is able to handle, and they would selectively reduce some of the infants, and that's another area that I would not work in. And again, in an emergency, I could go in and help the woman, with that. It would, taking care. Yeah, yes, yes. Help,
but okay.
But not with the activity of it itself. I would not participate in that. So I got more sophisticated, and I wish sometimes there had been a little more delineation or someone who had helped me. But I really had never worked in a Catholic hospital, and I didn't know any that many nurses, and really none that worked in obstetrics. And many of them worked in a Catholic hospital, so they didn't feel like they had to do anything like that to be able to declare that they were not able to participate in certain activities. So I, kind of felt like I was a little bit on my own. I had asked our priest.
There. You were
breaking
ground. And
yeah.
This is so valuable, Julie, because as there are other Catholics now who are hearing what you're saying, you're mentoring, in essence, on air, other nursing students who
right.
are, so please continue to share this. This is really valuable for them.
Oh, good. Well, that's it. Now I do, if I was to start another job, I would let them know what I'm able to participate in and what I can't participate in. And, some people say, well, what if they don't hire you? And I always say, do you really want to work somewhere that wouldn't honor what you need? Honestly, not that many nurses do any kind of declaration like that. I have been in administration, and I have to say I never once had a Catholic nurse say to me, that what they could or couldn't do. So I do think it's important to take that stand, and it's hard because I know at times people kind of made fun or, would say certain things or, oh, Julie can't do this, like making it sound like they had to do more work because I wasn't able to take that patient. But there were always plenty of patients to go around, and certainly no one had to take additional work because of it, but it just needs to be declared up front. And I would say at this point in time, originally I had just done it verbally and kind of wrote a note to myself, but I think now at this point, probably having some type of letter, just making sure that your manager knows. And also physicians also. I did work with one Catholic physician that did make that same declaration as like myself, and so there sometimes were sensitivities for him around taking call and things like that they had to work around that and be willing to work with that. And he, I assume, had told them up front that too, because they definitely did work around him, I know. And it was nice to hear that somebody else had, similar thoughts and feelings, and I didn't feel quite as alone, I have to say. But
my husband has had to do the same thing. I remember in medical school that he had to do the same thing. And the medical school he attended was a medical school with a Catholic tradition that had broken off and become a secular school. And the institutions that they did their rotations through, some were Catholic, some were not. And I do remember him doing a rotation with a individual who was not Catholic. And my husband had been very careful about delineating what he would do and what he would not do as a matter of conscience. And it is a freedom of religion. You have that right to be able to say that. We ought to have that right anyhow. And he had refused to give a injection of Depo-Provera to a woman. And the mentor physician yelled at him in front of the patient and said, "I hate you Catholics."
Oh, my.
And it was a very difficult moment, and he came home, and he's like, oh, my goodness, But I was so proud of him for taking that stand, and they know ahead of time, this is what you can do, this is what you won't. But as you say, you don't, unless you hear other physicians, other nurses talk about, this is the stand that I've had to take, and this is what I've done. This declaration is in writing or this declaration is oral. It's not something that is spoken of in such a way that other students are going to understand. So it's important that we talk about this so those who are listening realize they do have that right, and there is a precedent to be able to go ahead and do that.
Right. I do wish, and maybe there is something out there, that the Catholic Church did have a form letter that, us nurses and doctors could use sometimes just to put a bug in somebody's ear. That I think that would be a nice way for us not to, because it's hard to write a letter like that. And, you kind of are trying to walk that line of being a good Catholic and being a good nurse in the hospital. And so you want to be really clear, but it's hard. Like I said, as a new nurse, I didn't really know anything about this. I just kind of had said I was Catholic and, this is what I can kind of, I'm not doing. But even as a new nurse, I didn't know all the possibilities, and with new technologies and new meds and new things came forward that I didn't have any knowledge of, and how to figure that out at the time. And it would be nice to know that there's something coming forward that would be easier for us to utilize. I think knowing the sensitivity of where we're at, that there might be and to know that we're all using the same or similar form letter, I think would be very powerful. So who knows what someday we may have as a Catholic faith.
That's a really good point, Julie. That is something that we should really look at, seeing if it exists. If it exists, I'm not aware of it. And if it doesn't exist, that may be something we should take a look at developing.
Yeah, definitely.
Making more available to the different dioceses so that we are all using the same form. That's a very good point. So,
and good language, language that's honoring to our patients and honoring to our Catholic faith, and not just trying to henpeck it out as you're trying to figure out, what should I say? And, again, there's not people you can just say, knock on the door. I did go to our minister and ask, but he knew less than I knew about, honestly, all the procedures and things, and didn't have a lot of knowledge base other than that I shouldn't participate in an abortion. But I had already figured out there was a lot more things besides an abortion I had to worry about in obstetrics, and it was important to be able to delineate that out and understand it, not only from a religious moral point, but just from an understanding point. What does this mean, and can I participate in this or not?
Sure. I mean, in terms of tubal ligations and other issues, and I imagine over the 28 years of your practice, things that were not prevalent 28 years ago, as Humanae Vitae at that point was newly promulgated. Now, when we look at where we're at with birth control, sterilization, abortion, looking at New York and abortion up to a child in the birth canal. Things that when you and I first began, you as a nurse and I as an ethicist, we would never have imagined that.
Dreamed, yeah.
Right.
Yeah. It is. It's really important, I think, for anyone in any healthcare, practice or any kind of, even for, I would say, seminarians and priests, especially clergy that are within the hospital, for them to understand what are they kind of getting themselves into. So when they're called up to the obstetrics floor, what are they called to, and what does that mean, if she's having a miscarriage, or what does that mean if it's a fetal death and stillbirth? And you'll hear all these terminologies, like I had shared, I know, with you, Marianne, that the spontaneous abortion in healthcare is a miscarriage, is the spontaneous loss of a fetus or an infant from the mother's womb. And so that is, you'll hear doctors and nurses maybe call it a spontaneous AB or spontaneous abortion, but a woman might hear that and hear something completely different, that it's an abortion, where this is just spontaneously the body, doing that and miscarrying the infant. And but as a priest that would go in, or a nun or whoever, I think it would be really important, if you're working with that population, to kind of understand what some of these words mean and how they can impact the woman positively or negatively, and how she can kind of, you can support her the best way you can possibly. One of the areas that I sat on a few ethical committees. Every hospital is to have an ethics group that looks at things in an ethical light. And so I was privileged to sit on a couple during my time, kind of for that obstetrics viewpoint and in nursing. And I think that's where I really began to see how complicated some of these things are. And it is and it isn't. It's just there's things that you can't imagine could come up, and they do, and it's just it's amazing. I think that as priests, sometimes what they're saying is helpful, and sometimes I think I'm not sure they know always what all the kind of the background piece of this is and what it means to have a spontaneous abortion. What does that mean?
You're right. You are raising some great points. I'm sorry for speaking over you there and interrupting you. No, this is an excellent area. You read my mind with, because a good portion of the listeners for WCAT are Holy Apostle students, and many of them are seminarians or clergy, religious. It becomes really important to put this in that framework as well. Mm-hmm. I told you earlier, one of the things I like to look at is what should we do for individuals in formation, men in formation. What advice would you give? And you're giving some excellent advice. One is that terminology, and I've worked with the newly ordained or folks who are about to be ordained and have heard frequently miscarriage. It's one of those issues that they're not trained for necessarily in the seminary. It's an issue that they're uncomfortable with going to see somebody. And as a woman who has had miscarriages, I've had two. I lost my Francis and my Gabriel. I'm
so sorry.
Thank you. I know years later there's still pain, and people don't know what to say, and inevitably they say the wrong thing. And when that comes from clergy, the sting is even greater. You make an excellent point about spontaneous abortion. There's medical terminology, and then there's terminology that we use in everyday discourse. And if you're visiting a woman in the hospital and you've heard that there is a spontaneous abortion, that the body is spontaneously that the child is miscarrying spontaneously, if a woman overhears that, or her husband, or her other children, or her parents who may be visiting, and they hear the word abortion in there, they may take that word and accuse the woman later on of something. She may wonder whether she's done something wrong.
Right.
Just because of the misperception of a medical term that is used. So you make a very good remark there about folks educating themselves as far as the terminology, and for individuals who are in a chaplaincy program, I know there are some courses that deal with this, but the technology is changing so quickly. The language is changing, and as you and I have talked before, often the clergy have not had the privilege of having these courses and feeling comfortable with the terminology.
Well, I think it's not only clergy. I think in our culture also, there really aren't good cultural norms around miscarriage or around a stillbirth or something like that. We would know exactly what to do if your grandmother died, and we might send flowers, or we might send something in her name somewhere. We'd show up at the funeral home and calling hours, and maybe we'd go to Mass or liturgy, and there's knowledge and knowing about cultural norms around an individual that's been alive longer. But these that have been with us such a short time, these human lives that are just tiny and little, there's not really good cultural norms. And so what ends up happening, what I see, is that people end up being awkward and kind of bringing that awkwardness in with the mother, and then saying something that's kind of not correct, or saying things well-meaning. Like one of the sayings I've heard over and over is it was God's will.
Right.
And that is so not helpful for a woman to hear at that time, and that it just yeah. And
I love that book of Job where you have in the story of Job where you have his friends who came and they stayed with him for 7 days and 7 nights, and they said nothing. And it was great when they said nothing. As soon as they opened their mouths, it got really bad.
There you go.
And I've been on the receiving end of that, and I'm sure, I hope and I pray that what I've said to others has always been helpful, and perhaps it hasn't. But I know that being on the receiving end, I remember with one of my miscarriages, I had someone say, well, that's great. You should lose weight. This will give you the chance to lose weight. Didn't she want to do that anyhow? And
my.
I remember turning around, counting to 10, blinking back the tears that were stinging, and then pretending like I didn't hear the comment, because I thought it's not going to do any good to argue with this person or to let them know how deeply they've hurt me. But this is now, almost 20 years later, and that comment, I can still see what I was wearing. I can still see the moment and feel the sting.
Sure. It's devastating. It's devastating. And I always, when I'm teaching nurses, I always say in obstetrics, they're either going to remember you fondly or not. One way or the other, you're going to be a part of their birth story. And they're either going to think you're the best in the world, or every time they tell this story, they're going to say, wow, my nurse back then did whatever, doctor or whoever, because you're part of this amazing moment. And it should be a positive moment regardless. I always think when I have a woman that's having some type of loss, I always think this is her moment to be with this child for her entire life. So usually when we think of having a child, we not only have that moment of birth, but we have an entire life we think about them. We might have dreams and thoughts, and that they'll be married someday, they'll go to college, they'll be, whatever. We all have these thoughts and ideas, and so when you are with them during that moment of birth and death, all at once, it's really, really impactful to her what you're saying or not saying, to just be there with her. I always find the least said the best, that, I usually say I have no words, because there are no words. There's nothing I'm going to say that's going to help or that, but I can bear witness to what she's going through and try and ease some of the physical pain and emotional pain that she has during that time. Not take it away. We can't do that, but we can be with her, be truly present, so not be thinking about squirming out of your chair and kind of like, I can't take this another minute, it's too big, because it is big. But I think honestly and openly going into her room, knowing this is big, and being able to sit down and say, I am so sorry, I have no words for you. And is a wonderful way, and then let her drive where she wants to go with it. And I find women just need somebody who's willing to bear witness to their pain, and it's so beautiful when someone is willing to do that. I find priests are not always able to do that, and it would be nice if priests could, because they do such a great job most of the time when people have passed away and as an adult. Yes?
And they want to do such a good job.
Yes, yes, we all want
to. Right, exactly.
We all want to do a great job. So just know that this is, you're there doing the entire life of this child all in that one moment. And the research shows that these parents are forever changed. So they have a new baseline after this. I mean, this is the worst pain that parents say that they've ever experienced is the loss of a child, and that's at any time. It doesn't matter if they were there for 2 minutes or 20 years or 40 years, it doesn't matter. It's still their child. It's still all the dreams they had, the hopes, the desires, and they have to live that all at once. When I'm teaching nurses in obstetrics, I really enjoy the fact I say, listen, we're at the two greatest transitions. We are so privileged that we can be at the birth and at death. We are in obstetrics, and both of them are amazing. And they're both, you're really, really important what you say and how you are with them. So I feel like as priests and other practitioners, we can have that same idea that this is just like, a death, any death. It's different because they weren't here for very long, but they were still alive. And if we as Catholics can't recognize that, I mean, who's going to? I feel like that we're poised to be at the best position ever to be able to say, yes, this is life, and we will honor that and be honoring. And so all the wonderful things that we do to help honor that child, some of them just so individuals know, like we might take handprints and footprints. We'll use the casting like they have for dental work, and we'll give that to the parents. We a lot of times will take pictures, although now a lot of places, locations have photographers who really know what they're doing. Us poor nurses sometimes didn't give the best pictures always, but we tried our best. But the photographers that do black and white and do this beautiful, beautiful, just look, and it's really, really sweet when they do it. We many times will have like a box we give them to put everything in, so they have somewhere that's honoring within their home to have it. Some women like to put it in their closet. Some put it out on the table, their somewhere in their living room, and a lot of times nobody knows what's in it but them, but they said they feel strongly they want to have it somewhere where they see it. And then things change. Sometimes they keep it out for a year, and then sometimes they just put it back in the closet, and that's where it stays for the rest of the time, and they just visit it on special dates. That's the other thing, that a lot of times these women and parents, husbands involved, or in that they'll remember the due date. So they'll have that as a special date, or the day the baby was born, or, when their birthday was supposed to be. Also, Mother's Day and Father's Day is always a big remembering time for parents. So, I would assume that people might be seeking out priests and counselors and people like that to be able to help them through this. Or sometimes I've had people that have said, I'm not sure why, I'm just having a hard week this week. And, I've actually had women say, you know what, I forgot this would have been the week she was to be born. And, they just didn't think of it. And they see now why they're having this tough week, because there's these memory triggers, like the first Easter, the first Christmas, the first, whatever day was going to be special for them is always really important. I also take a lot of times a lock of hair if the mother and father want that, and if they have hair. Some babies have lots of hair and some not as much, but I take a lock of hair if they like that. I already said the hand footprints. Oh, I measure them. Usually I use our paper measuring tapes we have, and so I'll measure and put like the circumference of the head and the length of the body, anything that gives them some identification for the parents to be able to kind of touch and know, because sometimes they'll ask that later. I've had them come in, and honestly, I don't always remember their specific baby, but that's passed away, but I'll be like, let's look in the chart. I bet we have stuff there, and we'll try and look and see if we can, or, come up, they'll want something. The other thing that we do, a lot of times if they have a baptism, they'll use a shell or something like that to baptize. That goes in that memory box. And then we dress the baby, and if we can at all, we put that in. And then we definitely, usually there's quilts donated. A lot of times women will make quilts for hospitals, and we give them to women who have lost a baby, and that's something that they can take home with them. And I've had women tell me, again, some just put them away, but some use them for like a lap cover up and just think fondly of their baby when they're, covering and nice and warm and that with the blanket. The other thing we do, we try to involve all senses just like we do in liturgy, right? So we put baby powder on a lot of the clothes and that, because sometimes, the baby doesn't smell as well as you'd like, and so that's way it kind of has a positive spell. Most women do associate baby powder smell with babies, so we do all these things. And what women ask, like sometimes they want to go outside, sometimes they want to hold them in the garden, anything they want, we really try and honor that. The other thing I've seen where priests sometimes have intervened, and it's been interesting to me, is we put the baby usually in a cooler so it stays, cooled, when the mother isn't with the baby. That first day she has them, but after that, and then if she wants the baby back, we bring it back. We don't always call the funeral home that they know they're going to get it, but we don't know when that's going to happen. Right. And most mothers want to hold that baby again, and I've had individuals that have said, no. Sometimes the fathers will say it, sometimes priests. Even I've had a few physicians, and it's really unfortunate because it shuts her down because she feels like she's asking something that's wrong, to be able to see and hold that baby again. But again, just back to the premise that we're trying to give her the whole life of that child in those few hours or days. And as many times as she wants to hold that baby, I will go and get it and bring it back so that she can hold it. And we make sure that, that nothing will happen with the baby until she's ready for that to go, like an autopsy or things like that, that we have to be concerned about. So that's something else we do. And then lots of hospitals have like Resolve Through Sharing is one program, and that nurses can go through, and physicians and other healthcare workers, to be better prepared for that. So if that's an area that you're going to be a part of, especially, working in a hospital or anything, it'd probably be good to get some specialized training around, early loss and how you can best support the mothers and families.
Wow, Julie, you have given so many suggestions. Just a wealth of knowledge here. I love the way you bear witness and an effective nursing strategy here. Do what has to be done to allow this mom and this dad, this family, to know that this child is here, that this is a child. And as you said, if we as Catholics cannot acknowledge that this life, however short it was, in terms of gestational age too, this is a life, this is a human person. I think that is the most pro-life thing we can do. And this family is going to carry this grief with them forever, literally. As you said, there is nothing that is harder than the loss of a child. And you as a healthcare worker have the opportunity, it is a very privileged point, to be there at the beginning of that child's life and at the end of that child's life. And you're right, you're going to be part of that story whether your influence has been positive and whether you have allowed this family to bear witness and honor this child, or whether you rushed them and whether you've taken away something from their experience. What a beautiful ministry, in essence, that you have here as a highly educated nurse, to be able to teach young nurses and others the art of bearing witness, of spiritual accompaniment at this particular moment. It's a tremendous gift and privilege that you have to be able to do that. And thank you for sharing that here. That's enormous. So far, you have given great advice for young professionals who are just starting out in medicine, in nursing, in other aspects of medicine, to know that, yes, as a Catholic, no one's going to come to you and say, hey, here's a form. Could you just check off what you're willing to do and what you're not willing to do? You're going to have to be proactive and say, as a Catholic, I know my rights, and as a Catholic, I am not able to be a part of these procedures. I am able to, in a case of an emergency, step in and take care of the patient if they are bleeding or anything else, but I will not be going in for an abortion or a selective reduction or a tube tying or anything else along these lines. And that these young professionals are going to need to know that. You've also done a tremendous service here talking in terms of young medical professionals and clergy about the experience of loss around obstetrics, of fetal loss, of miscarriage, of stillbirth, and just how uncomfortable it is, but what a privileged moment they're having there, and what they are able to do. They are the face of God right there. They are bearing witness. They're doing what the guardian angel is doing right there as well. As we look at we've talked about loss. One of the ethical issues that I've dealt with is, what about adoption? When you are there in a obstetrical setting and you have a child that is being relinquished, or you have a mom who's had a crisis pregnancy and she is still vacillating, how do you handle those decisions? How do you handle nursing in those cases?
Yeah, usually in an obstetric unit, most of the time those decisions have been made before they come to us. But if it hasn't been made, there's usually policies around, each organization has it, kind of whether the I guess I better go back. It depends. Some of the states are different. Before I answer some of this, their laws about adoption and that. So some of it would vary based on that. Like some of the mothers, if they're unsure, what my experience has been, they keep the baby. If they're honestly that unsure at the moment of delivery, and that they want to see how they'll feel when the baby's born, and I would say most of them can't give it up. It's their baby then, and they hold it. As far as an adoption, those mothers, a lot of times they'll either want to see the baby or they just don't want to see it, or kind of don't want to do anything with it. And a lot depends on whether it's like an open adoption versus like a closed. And so with an open adoption, the birth mother is going to be a part of their life. So however that arrangement looks, it's usually kind of legally set that they have, they'll see them on holidays and birthdays or whatever. I'm just kind of making something up, but they kind of have that open adoption. But then a closed, if they don't know the mother and that's closed, then the mother a lot of times doesn't want to hold the baby even in that initial time. I mean, I offer that to any mother because she's allowed to make that decision, but if she's really like a young girl and really unsure of it or whatever, she's not going to want to hold the baby many times, and then it just moves over to the nursery, and it's kept there until it's, okay to be discharged, and then sometimes we keep it a little longer depending on whether it's going to a couple or, if it's already been arranged, or it might be, it just depends on what the situation is.
The reason that I'm asking in this sense, one, I have 3 children, 3 of my 8 are adopted, but I'm also thinking in terms of loss, because the woman who is relinquishing her child to adoption is doing something tremendously courageous. She has realized that she gave life to this child. She brought this child to life. She chose life, which is a tremendous step and a huge gift. She's given this child the best gift that anyone can. She's given this child life. She's also taken stock of her life and realized that she is not able to raise this child and that there is someone else who can. But for her, there's also a sense of loss. And I'm wondering how that comes into play in terms of nursing care.
You're right. I mean, definitely there is a loss, and talk about people being awkward with these poor moms, like they sometimes it can get difficult because, like OB is a happy place usually and stuff. So if their baby, we usually have an indicator. Most organizations have like a balloon, a picture of a balloon they'll put, let's say, if a death has happened. So no one comes in and inadvertently like delivers lunch and says, oh, how's your baby, when there is a loss. But when there's an adoption, some organizations didn't have that, but now I hope most do have that. They have some symbol, whether it's a rose or whatever, that means that the adoption's happened, and that way they, when you go in that room not to say something inadvertently that would be callous and awful. So these mothers a lot of times don't feel as comfortable going to a perinatal loss group. They really do sometimes suffer silently, and I do think reaching out to them, you're 100% right, in a way that's honoring for what they've done and the sacrifice they've made, whether it's an open or
charity there. It is absolute heroic charity. I pray every day for the birth moms of my 3 that are adopted, because what they have done is huge, and I think that has got to be something that we, again, as Catholics and pro-life Catholics, we've got to do a better job of supporting these women, because there has got to be a sense of grief or of loss there too as they pass birthdays.
Sure, of course.
And I'm sure there is joy knowing that child has gone on. There's a sense of accomplishment. Yes, I brought, this child to birth, as difficult as it was, and I did relinquish this child to a better life. But I think you're right. I think there is also a tremendous loneliness at times if the rest of us don't get it together and validate the great good and the heroic charity that these women have shown.
And the other thing about these women, we do offer, if they want to not be on the obstetrics floor and want to go on to another unit, medical, surgical, or something like that, so they're not around all the babies. It's interesting. A lot of nurses will offer that to women who have had a perinatal loss, also where they've had a miscarriage or fetal death, and it's interesting. The reason they do it is so they won't be exposed to the babies, but most mothers say that they want to be on the unit if you offer it to them. I always offer it to them. What would you like? And I always say, here's the pros and cons. So the pros are you're going to hear a baby cry at least once, if not multiple times, And for a lot of mothers, when I've talked to them, the first time they've heard a baby cry is in the middle of the grocery or somewhere else they're at with no support around them, and they just are devastated. So I said, I would rather you be here and have that with our support around you than to be in the middle of the grocery store. So it's interesting that we offer it with both of them, but most moms that have had a loss want to stay on the unit because we are, specialized in that. And if they just go to medical, surgical, not that the nurses can't care for them, but it's, they just don't have all the, all the knowledge that we have and with helping with that. But sometimes if an adoption's happened, that mother does want to leave the unit and wants to be cared for on a different unit.
Wow, that is fascinating too. And thank you for sharing that. I remember my pregnancies were high risk. I had one after another. I had a complete previa with one, another, just lots of issues with each one of them, and I was always on the high risk end of things, and just the care that is taken to make sure that you have the right folks who are interacting with you and that you're on the right part of the floor. I do remember one of mine, daughter number 1, child number 2, goodness gracious, that child had a cry that could break glass. And my room was right next to the nursery. And I remember after a very difficult C-section, having labored first and having a section, thinking, oh, goodness gracious, who is that with that cry? And then the nurses brought in a swing and said, we're going to keep this one in here. This one's yours. And I remember sitting up thinking, the cry? Yeah, she's disturbing everybody else in the nursery, so she's going to be in here with you.
Yeah, and disturb you, right? The beginning of many years.
Oh, goodness, she's a Holy Apostle student now. In terms of faith, in terms of prayer, how do you, I'm sure your prayer life keeps you going. How do you walk the line between leaving what you have to leave in the hospital and coming home and turning it over to God? And how has your vocation as a nurse interplayed with your vocation as a Catholic?
Obviously, you're right. My prayer life is really, really important to me. But there is a certain amount that you have to leave at the door. I always say when I've had a particularly hard day at work or, whatever's going on, I literally, in my mind, make it that I leave it at the door. And when I come into my home, it's a place, it's a sacred place of just care and love and hopefully maybe not all the time, but and it's a refuge from the outside world, and it needs to be that place. And I can't be having the problems of my day be carried with me into your home. You just can't have that. It just I really do think that I make that choice. I leave it at the door. Now that doesn't mean I don't pray for all my patients, and I have, and I pray when I'm at work. I'm constantly, praying as I work and that. But I would feel almost like I was crazy, I think, if I tried to bring it home and kind of, spend time with that in addition to all the hours you spend at work with it. So I do make that choice, and I try not to bring it home. If something does, I do depend on my husband to be able to support me, and because not everything you can leave totally there at work, but I think as you get better at it, and then if you have questions, things like that, I mean, that's when I need my husband. I might reach out to my priest, and that, and try and clarify things. And then sometimes I just need to cry a little. I come home and I'm having trouble leaving it at the door, and I just need a good cry and a good night's rest, and you begin again tomorrow morning, right? And know that that's part of the work I've chosen, and I'm glad to carry that with my patients, knowing that it is a difficult. I'm not stamping widgets at the factory. Not that that's not holy work too, but I'm with these women, and it's going to have there's going to be days harder than other days, and I just think that there does need to be some separation, but it's hard. It's not always as easy as you'd think it would be.
Oh my goodness, you do such a tremendous job. So much of what you've talked about here has come across in terms of mentoring, of what you've been able to teach other young nurses, the advice you have for others in a medical profession, the advice that you have for others in chaplaincy, or young men in formation, women in formation in essence too, who are religious women. Is there anything that you do with your parish that helps your parish or your diocese? I know that you work very closely with your bishop. Is there anything that you do to help mentor Catholic nurses?
There's, other than just one-on-one, talking, we're a pretty small diocese in that. So I think, especially if I know someone's going into nursing, I always try and take some time and, at my church or wherever I hear about them, and spend a little time and mentoring and talking and just, saying, have you thought about obstetrics? And, of course, I'm always love my obstetrics area and stuff, but not a formal program of anything, but just informally. Of course, whenever I hear someone wants to be a nurse, I encourage and support them and try and be positive about it, and, encourage them and in any way that they might be struggling with something ethically, or they might be struggling, how are they going to do this or that? It's a process to become a practitioner, and so it's not without its bumps.
Oh, you have this art down to a science. You really do. You do such an incredible job. One of the issues that I'm forever working on, one of the issues that always comes to the forefront for me is informed consent. And I think it's huge. In fact, I'm probably going to devote an entire show to informed consent at one point. And you've hit on this several times throughout the course of this interview, which we're actually getting very close to the end of, believe it or not, is the knowledge base that's out there. We talk about patients who don't have the biological knowledge. It's not being taught in school. The medical knowledge, because we're talking completely foreign vocabulary at times over their heads, and they rely on their clergy to come in and help them make decisions, but the clergy may not have the knowledge base either. And I see that as a tremendous problem that is really becoming a greater issue. And it's the issue of informed consent. For truly authentically informed consent to occur, there are certain substantive elements that have to be there. And the patient has to know exactly what the options are. If I consent to this C-section, this is what's going to happen. If I consent to this medication, these are the pros, these are the cons, these are the risks, and these are the likelihood of these risks. And yes, knowing all of this, both what is going to happen to me now and what is going to happen to me in the future, I am willing to take that risk. That's truly informed consent. Having someone come in and say, hey, the doctor ordered this, you have to take it, is not informed consent.
Correct.
And I see that as a real issue that needs to be worked with. Do you have anything to say on that one?
Yeah, well, again, back to my living and working in different regions, it's interesting how informed consent is kind of handled. Some organizations have the nurse actually witness that the patient's been given informed consent. So I'm not only witnessing her signature, I'm witnessing that she understands what she's signing and doing. So to me, that's a whole different level of that is informed consent versus witnessing a signature, which some organizations, that's what the nurse is doing, is witnessing. As a registered nurse, though, I'm an independent practitioner, and I do need to, in my mind, be able to make sure that they understand to the best of my abilities what they're signing up for. And so if I see something happening that I think she still has questions, I absolutely, unless an emergency, which is a completely different situation, but I absolutely will call the physician back and ask that he or she spend some more time with them, answering more questions. And I don't hesitate to do that. I mean, obviously some might be frustrated or that, but most are glad that, somebody else is kind of watching the store, if you will, saying, wait a minute, she really doesn't understand what you're talking about. And, so as an advocate for the patient, I feel it's very important that I do witness that they have had an informed consent to the best of my abilities. And if they don't have that, it's up to me to be able to facilitate getting that to happen so that they are knowledgeable. And if they have a question that I feel comfortable answering, I can answer it. But I always try to let the physician know, because that's important to him or her too, that, your patient's having trouble around this area, and we're still asking me questions even after you left, after you if you will, did the informed consent. And I think as complex as healthcare is anymore, I don't think it's a one-time deal either. I don't think you just do it once and you walk away. Most things that are where informed consent is really important takes a while to digest it, to think about it, and to be able to understand what it means to do it or not to do it. Both ways, it's not just the affirmative to do it. It's like, what if I choose not to do it? What then?
Exactly. You always have unless it's an emergency, you always have the option to do nothing. And
right.
So much of what I see in informed consent is a legal covering oneself, and it is not just the, we're going to, quickly check boxes and obtain your signature so we can say we've done informed consent. And I see that as a real problem in terms of, it used to be just in terms of language. Perhaps in this population, this is a Hispanic population or a Hmong population, or a population that is not speaking the language of the physician. And so we've got to be extra careful. But I really think that in terms of the technology and the science, we are not conveying that appropriately, and especially in things like obstetrics, high-risk obstetrics, fetal-maternal conflict. In terms of medicine, where we're dealing with people at the most emotional times of their lives. And I think it's an issue that we've got to take a better look at. Julie, we're at the end of our time, and we can go for another hour. But I know you got to get to dinner, and I am so grateful for you to spend your time with us, and I hope you'll come back and do it again. Do you have
thank you so much.
Any parting words of wisdom?
I think sometimes we complicate things, and some things are complicated, but all life is sacred, and I guess that's was kind of rolling around in my mind as we were talking some, that sometimes it's good to talk about these complicated things, but just remembering that all life is sacred, and that we need to remember that and approach it as that. And I think some of this stuff could iron itself out a little better if we kept it a little more simple in some areas than we do. So
I do, and I think from everything we've discussed here, you beautifully encapsulated that at the end. With everything we've discussed, if we can just remember that sacredness, that inviolability, the inviolable dignity of that human person, however teeny they are, and of our patient, of the mom, the dad, the family, the child, if we can just remember that sacredness of that gift of life that comes from God. And putting this all in His hands, the show in His hands, and thanking you again for being my guest here.
Well, thank you for having me, and thank you to everyone that's listening.
Well, for this week's episode of Inter Vitam at Mortem, discussion and interviews with a Catholic bioethicist, I'm going to say good afternoon and goodbye for WCAT Radio. But thank you, Julie.
Thank you.
We hope you enjoyed the program and will join us back for another show on WCAT Radio. This is Sebastian Mahfood. Good day.